and the brainstem begins its myelinization and progress at birth. And for us to be able to check the brain development is because of this one. The lack of myelin and incomplete skull ossification permits brain to be seen sonographically throughout gestation. But then again, as the fetuses mature, no, those neurons are in sheet now with myelin. Okay, and then there will be definitely a complete, no, not incomplete skull ossification as the fetus progress. Okay. Now, how about the spinal cord development? Okay, so 2/3 of the neural tube gives rise to the brain, and the inferior 1/3 forms the spinal cord. By the 8th week age of gestation, the synaptic function is fully developed with flexion of the trunk and the neck, no, exhibited by the fetus. Ito yung sinasabi ko sa inyo. As early as 7 weeks, there is already somatic movement kasi nagkakaroon na nito. Okay? And then, by the 21 weeks, the entire sacrum is already ossified and visible sonographically or by ultrasound. Okay? By 3rd trimester, there is rapid integration of nervous and muscular function. So that's what happened in the cranial or in the central nervous system of the fetus. The central nervous system is one of the most vulnerable. Okay? That's why even if they are usually developed during embryonic period, once they reach the fetal period, no, lahat yon, it spans. The brain is usually trying to mature, so any insult at any trimester, pwedeng maapektuhan yung brain development ng fetus. Okay? Next is the cardiovascular system. Okay? The cardiovascular system, this is a little complicated in the fetus because remember, they are not using the lungs, no, their lungs to actually oxygenate the blood, correct? May mga bypass na dinadaanan yan. That's why they avoid the the pulmonary vasculature, okay? So the cardiac tube is formed by the 23rd day following an intricate morphogenic sequence. By 4 to 7 weeks, the heart undergoes extensive growth and morphologic modification, leading to the formation of partial septate 4-chambered heart with a set of primitive valves. Okay, so that's how important it is. That's why, if again, insult will happen between 4 to 7 weeks, then definitely, since this septate or divisions are starting to develop, pwedeng magkaroon yan ng mga ventricular septal defect, no, atrial septal defect, dito yun nagkakaroon. Okay? And later in life, coronary angiogenesis vascularized the myocardium. Now, what about the fetal circulation? Okay, please remember that inside the utero, the fetus has a placenta and the umbilical cord attached to it, right? So it's actually the umbilical cord that serves as the oxygen, or serves to give the oxygen, no, to the fetus and not the lungs of the fetus per se. Okay? So, in the umbilical cord, di ba may tatlo kang vessel dyan? We call it AVA. 2 arteries and 1 umbilical vein. It's the baliktad kapag umbilicus ang pinag-uusapan. Okay? Kasi di ba normally speaking in adult, the vein carries unoxygenated blood and the arteries are the one that carries oxygenated blood. But in the fetal circulation, it's the other way around. It's the umbilical vein coming from the placenta that delivers oxygen and nutrients to pass either in the ductus venosus or the portal sinus. So this is the umbilical vein. It goes to the liver. No? In the liver, you have two, parang dalawang conduits na pwede niyang puntahan. Either the ductus venosus that traverse the liver and enter the inferior vena cava, carrying well-oxygenated blood, or to the portal sinus. So from the umbilical vein, ductus venosus or portal sinus. If the portal sinus will be the one to be entered by this blood coming from the umbilical vein, this brings blood to the hepatic veins on the left side of the liver where oxygen is extracted, carrying less well-oxygenated blood throughout the inferior vena cava. Okay? So how does your fetal circulation differ from an adult? In the fetal circulation, we call it as parallel. Okay? Sa adult kasi series, right? Inferior vena cava, right atrium, right ventricle, pulmonary circulation, left atrium, left ventricle, then aorta, right? So it works in series. In the fetal circulation, it differs from the adult circulation because first, it works in parallel, and second, pulmonary vasculature is usually bypass, okay? So it works in parallel and not in series as compared to adults. So again, what happens is the two separate circulation are maintained by the right atrium where blood is directed either to the left atrium or right ventricle by discrete dividends depending on its oxygen content. Now, the well-oxygenated blood enters the right atrium, okay, and preferentially shuns to the foramen ovale, going to the left side of the heart, supplying the heart and the brain. Okay? Yun yung well-oxygenated. So, inferior vena cava, right atrium, di ba usually bababa dapat sa right ventricle. But in the fetus, what happens is, from the right ventricle, there is a small opening going to the left atrium, and we call it pulmonary, foramen ovale. Okay, so that from foramen ovale, okay, it will now supply the heart and the brain. And then the less oxygenated blood enters the right atrium, pababa naman. Okay? Deflected by the tricuspid valve to the right ventricle and courses through the descending aorta to supply the rest of the body. So that's why it's called parallel circulation. Next, how does it avoid the pulmonary circulation? So definitely, the blood coming from the heart doesn't pass through the pulmonary circulation, not unlike our cardiovascular system, the cardiovascular system of the adult. So in the fetus, what happens is that 90% of the blood coming from the right ventricle is shunted to the descending aorta through the ductus arteriosus. Okay, so the ductus arteriosus, I hope you can see my cursor, is somewhere in this side, in the descending aorta, sa top. Kanina, ductus venosus, nasa liver yon. Ito, ductus arteriosus, nasa descending aorta. Okay, bypassing the lung vasculature for oxygenation. So it's the conduit of the ductus arteriosus that makes the blood, that prevents the blood from entering the pulmonary circulation. And another reason, doktora, ba't hindi nga pumapasok sa pulmonary circulation? Ang liit-liit ng ductus arteriosus niyan, tas ang daming blood. Because during fetal period, the pulmonary vasculature pressure is very high. No? So it repels blood na papasok sa kanila. Okay? Then, ito yun, high pulmonary vascular resistance and comparatively lower resistance in the ductus arteriosus, kaya nagkakaroon siya ng bypass. Okay? So, only 8% of the right ventricular output goes to the lungs. Okay? So, very small amount. 1/3 of the blood passing through the ductus arteriosus is delivered in the body and the rest returns to the placenta through the hypogastric arteries. Okay? Now, syempre, after birth, changes usually happens. Kasi once it still remains patent, no? Kunyari, patent ductus arteriosus, di ba naririnig nyo na yon? You will meet that on your pathology class, okay? Or in your pediatrics. Yun yung mga butas sa puso na hindi nag-close after delivery. Because ideally, those conduits or those small opening that is used as bypass during fetal growth or fetal development or fetal period, it should close after delivery. Okay? So, postnatal umbilical vessels, ductus arteriosus, foramen ovale, and ductus venosus should constrict. This is what I am telling you. Okay? So, with lung expansion, definitely after delivery, hihinga na yan kasi nakalabas na siya, no? Wala na siyang umbilical cord, right? So, with lung expansion, ductus arteriosus functionally closes, and blood coming from the right ventricle enters the pulmonary vasculature to become oxygenated before it returns to the left heart. So once it closes, nagkakaroon na ng series, hindi na parallel. Okay? And this is what happens to the remnants of the fetal vessels. And I know this was already also discussed to you in your histology or your embryology. Okay? The ductus venosus becomes the ligamentum venosum after constricting by 10 to 98 hours postnatally and closes anatomically by 2 to 3 weeks. Intra-abdominal remnant of the umbilical vein becomes the ligamentum teres. Hypogastric arteries becomes the umbilical ligament. after undergoing atrophy and obliteration within 3 days. Okay? So these are the things that actually happens. Again, the postnatal circulatory changes, foramen ovale closes, no? The ductus venosus constrict and becomes the solid ligamentum venosum. The umbilical arteries constrict, okay? Ductus arteriosus constrict and becomes solid ligamentum arteriosum. Okay? And umbilical vein becomes solid ligamentum teres. And once this happens, or once this circulatory changes happens, the ventricle now that previously starts in parallel after delivery, no, fetal life now effectively will work in series, or fetal circulation now will work in series. Okay? So again, your cardiovascular system or the circulatory system in the fetus, it's usually parallel and it bypasses pulmonary circulation. But after delivery, these openings, no, as a bypass that was used to bypass the pulmonary circulation should close so that from parallel circulation, it will now function in series. Okay. Next, hematopoiesis. The site of hematopoiesis, you're also aware of this one, even in your physiology, this was already discussed to you, that during the first trimester, the site of hematopoiesis is the yolk sac. Second trimester is in the liver, and third trimester is in the bone marrow. Okay? When you're talking about fetal RBCs, they usually are nucleated. And sa adult hemoglobin, the adult RBCs or erythrocytes, usually, the lifespan is 120 days. In the fetus, mas mabilis. The lifespan is only 90 days. Okay? So, erythropoiesis in the fetus is usually primarily controlled by erythropoietin and influenced by estrogen, prostaglandin, testosterone, lipoprotein, thyroid hormone, and importantly, by fetal hypoxia. Okay? Now, fetal hemoglobin, the difference between the hemoglobin F and the hemoglobin A. Hemoglobin F usually binds more with oxygen than your hemoglobin A because your hemoglobin A binds with your 2,3-diphosphoglycerate more avidly than your hemoglobin F, thus lowering the affinity for oxygen. So, this is the reason, or the differentiation between your hemoglobin A and your hemoglobin F. Okay? How about coagulation factors in the fetus? There is actually no form of hemostatic proteins. Di ba sa atin may mga iba-iba kayong factors, may mga fibrinogen, no? May mga prothrombin tayo sa loob ng katawan natin that actually prevents bleeding or is used for coagulation. But during fetal life, there is no actually hemostatic protein except for fibrinogen. Okay? I highlighted the vitamin K because again, if you can still remember, the vitamin K is usually produced in the intestine, right? And since the intestine or the GIT of the fetus is still mature, then what happens is this vitamin K konti lang or halos wala. No vitamin K production at all. And again, if you can still remember, the vitamin K is very important for your factors 10, 9, 7, and 2 to promote coagulation. That's why since they're lacking vitamin K, what happens is after delivery, prophylactically, not the fetus, the baby or the neonate is given a prophylactic shot of vitamin K. Ini-injection yan sa kanila. Okay? So, this is given after delivery to prevent bleeding problems immediately after giving birth. Okay? Now, plasma proteins, what is important? This fetus produces liver enzymes and plasma protein which do not correlate with maternal levels. At birth, mean total protein and albumin concentration in the fetal blood are similar to maternal levels. This is important because albumin binds to unconjugated bilirubin to prevent kernicterus in the newborn. Okay. How about the respiratory system? So when we were talking about respiratory system, the morphological or functional immaturity of the lungs will lead to the development of respiratory distress syndrome, right? That's why if the fetus should be delivered no? By emergency kasi something is happening sa kanya sa loob. The later delivery, the better. Kasi lungs ang pinaka-late nagmamature. Okay? This is the most dreaded complication if we have to deliver the fetus preterm, baka kasi hindi pa mature yung lungs niya. So if hindi pa mature yung lungs, then definitely there will be higher incidence of the respiratory distress syndrome. So how does the respiratory system develops? No? You have different stages. You have the pseudogranular stage that happens around 5 to 17 weeks. No? There will be growth of intrasegmental bronchial tree. Next is the canalicular stage, 16 to 25 weeks age of gestation. There will be presence of terminal bronchioles giving rise to respiratory bronchiole and terminating as multiple saccular ducts. Then you have terminal sac stage, presence of terminal sacs which arise from the primitive alveoli and extracellular matrix. Next would be the alveolar stage, the last stage, no? Late in the fetal period. Extensive capillary network with formation of lymph system and production of surfactants by type 2 pneumocyte. Okay? So what happens if there will be insult? Because again, if there will be immature lungs, the patient or the fetus is prone to develop respiratory distress syndrome. Aside from that, insult happens sometimes in different stages, right? So if insult happens during embryonic phase, then what happens is there will be esophageal tracheal atresia or your tracheoesophageal fistula and pulmonary agenesis may develop. Okay? Another insult is your anhydramnios. Pag sinabing anhydramnios, walang water or walang amniotic fluid sa loob ng uterus. Okay? And this usually happens secondary to fetal renal agenesis. Kasi syempre, how does amniotic fluid, how is amniotic fluid regulated inside the utero? Okay, by continuous lunok, ihe nung fetus, no? Nilulunok niya amniotic fluid niya, iniihi niya ulit yon, nilulunok niya, iniihi niya, so that there will be hemostasis in the amount of amniotic fluid. So, how will the fetus urinate? Syempre, dapat may urinary system siya, just like us, right? But if the urinary system is defective or there is an insult and that was the one which will become defective, then there will be no production of your amniotic fluid. And anhydramnios will result to defects in all four development of the lungs. Ibig sabihin, totally, hindi siya magkakaroon ng maturation. Okay, so that's how important the amount of amniotic fluid is. Another is oligohydramnios. When you say oligohydramnios naman, mababang amount of amniotic fluid. Okay, so what happens is it also affects the lung development. Okay, and another is if there will be deficiencies in vitamin D, this will also affect the fetal lung development. Okay, how about pulmonary surfactant? If you can still remember, pulmonary surfactant in the respiratory system is very important because this prevents the lungs to collapse, right? This is formed by your type 2 pneumocyte that lines the alveoli, composed of 9% of your glycerophospholipid and 10% of your protein. Okay? So surfactant must uncoil the lamellar bodies and spread to the alveolus in order to prevent the collapse of the terminal sac during the first expiration after birth. Okay? And this is yung unang hinga niya after delivery. Okay? Now, what should we do in cases wherein we have to deliver the fetus and the fetus is not yet term? What we usually give are your antenatal corticosteroids, as what we call it. It's either in the form of betamethasone or dexamethasone. These two medications are usually given intramuscularly if sa mother, hindi sa fetus. I-injectionan yung mommy, okay? Intramuscularly, either of the two, whichever is available, to hasten lung maturity just in case we need to deliver the fetus. Okay? Tapos preterm pa. And what happens is, once we give that, this stimulates the fetal cortisol for lung maturation and surfactant synthesis, enhancing preterm fetal lung maturation. If you will ask me, Doktora, routine po ba? When you say kasi routine, ibig sabihin, every time binibigay mo or pinapagawa mo. Okay? So we do not give antenatal corticosteroids routinely. We only give that if we have to deliver or there is an impending future early delivery for that fetus. Okay? Kung kailangan or kung halimbawang natatansya mo na baka mag-deliver to ng maaga before term, no, before it reaches term, then you have to give corticosteroids. And then again, this actually helps to hasten the lung maturity. Okay? Next is the digestive system. So this is what happens to the digestive system. You have the foregut, no, midgut, and then you have the hindgut. Now, the critical importance of knowing what happens in the digestive system is that this one, the above information, improper rotation or fixation or partitioning of the structures can result to the malformation of the GIT. You will also meet this in your pathology, yung mga megacolon, no, volvulus, or I think in your pediatrics, okay, you will meet the different abnormalities that happens in the digestive system. Again, this happens during the embryonic insult that happens during the embryonic period. This is what can happen, okay? So aside from that, no, what another importance of the digestive system is again the regulation of amniotic fluid. Syempre, 'di ba pag lumulunok tayo, pagka lumunok ka ng pagkain, saan ba yun pumapasok? Pumapasok yan sa mouth, esophagus, pupunta sa intestine, and then lalabas. Correct? So in the fetus, hindi naman sila nagpupupo sa loob. But how do they regulate the amniotic fluid? By the help of the digestive system. They try to swallow it. Okay? That's why if there will be problems in swallowing of the amniotic fluid, what do you think will happen in the amount of the amniotic fluid inside? Kanina, if the kidneys will be the one that will have a problem or abnormality, hindi makakaihi yung fetus. Bababa yung amniotic fluid. Now, what do you think now will happen if there will be now problems naman in the GIT? That prevents the fetus to swallow the amniotic fluid. What will happen to the amount of amniotic fluid? Anybody from the group? Or if none, can I call Dr. Lim Oliver? What will happen to the fetus? Oliver Lim. The amount of the amniotic fluid inside. If there will be defects in swallowing.
Doc, mag-increase po ba yung amniotic fluid?
Correct. This time, dadami naman. And we call it hydramnios. You're correct. Okay? Kasi, hindi siya nakakalunok. So, ihi lang ng ihi yung fetus, mapupuno. Okay? Dadami. Not mapupuno. Sorry, dadami. Okay? So, we call it hydramnios. Again, if the fetal kidneys will be the problem, walang iihi. So, konti ang fluid. Oligohydramnios or anhydramnios. Pagka naman GIT ang problem, hindi siya makakaswallow, maiipon. Kaya dadami. We call it hydramnios. Okay? Now, what about meconium? When you say meconium in fetus, no, this consists of desquamated fetal cells, the vernix, lanugo, glycerophospholipids from the lung, scalp hair, and undigested debris from swallowed amniotic fluid. The color of the meconium is usually dark greenish black in color due to bile pigments, especially biliverdin. If you see a meconium sa mga baby nakakapanganak, napaka-lagkit niyan. Okay? That's why, just in case the meconium, nakapupo na yung baby sa loob, and once they aspirate it, they can have problems in breathing. And we call it meconium aspiration syndrome. Because once this meconium goes inside the lungs and gets into the alveoli, natatrap niya kasi or nababarahan niya kasi even the bronchial tree. That's why there will be difficulty in respiration. Kaya nga kapag buntis, we prevent the meconium passage as much as possible. And what are the reasons why we have to, or what are the reasons why meconium passage happens? First is normal bowel peristalsis. Baka kasi mature na yung fetus. Okay? That's why we avoid to deliver fetus who is already post-mature, more than 42 weeks. Okay? Second is vagal stimulation. When does vagal stimulation happen? Once the head of the fetus passes through the pelvis, remember that's bone, right? So masikip yun. Nagkakaroon ng vagal stimulation. Sometimes the head is a little, nape-press ng konti, producing vagal stimulation. Kaya paglabas ng fetus, pag-deliver nyo, pagkuha nyo sa fetus, minsan sa puwet niya, naka-meconium passage na siya. So 1 and 2 is actually physiologic. Okay? But then again, as I have mentioned, we prevent meconium passage or delivery of a fetus who is already post-mature because of these two physiologic reason why meconium passage can happen. Okay? But you have the third. The third is something pathologic. Okay? And this meconium passage can be a result of hypoxia, which stimulates the arginine vasopressin to stimulate the colon of the smooth muscles to contract, resulting to intraamniotic defecation. How does hypoxia happens? Most common is, for example, asphyxiated na yung fetus sa loob. Kunyari, may complications ang mommy, hypertensive ang mommy. No? So, hypertension can actually cause the fetus to pass or to have intraamniotic defecation. Kasi konti lang yung oxygen niya because ang mommy niya hypertensive. So hypoxia happens. And again, this stimulates your arginine vasopressin to stimulate the colon's muscle to contract. And then, it promotes intraamniotic defecation. So mostly, fetus who are asphyxiated, no, or kulang ng oxygen sa loob, nagkakaroon din ng intraamniotic defecation. And even if that is a premature fetus, that can happen because again of the hypoxia. So this is something pathologic, the third reason. Okay? So the complication is again meconium aspiration syndrome, and this is the most dreaded complication. That's why we try to avoid this. Okay? Liver. So the liver, fetal liver actually has a gestational age-related capacity to conjugate bilirubin from hemoglobin breakdown. Okay? So the capacity of converting free unconjugated bilirubin to conjugated form is again gestational age-related. Thus, premature neonate having unconjugated bilirubin is at risk for hyperbilirubinemia. And this is one of the common reason why kapag pinanganak yung baby, minsan mabilis manilaw or nagdidilaw sila. Because again, of the immaturity or sometimes or not sometimes, kasi minsan halos maraming baby talaga na lumalabas na mabilis manilaw. It's because of the incapacity of the liver to conjugate. Okay? And what happens, di ba nagkakaroon ng yellowish discoloration ng skin. So the earlier the delivery is, especially for preterm, mas prone magkaroon ng hyperbilirubinemia ang fetus. So as much as possible, again, if without any indication, we have to deliver the fetus term. And term pregnancy starts at 37 weeks. Okay? Now, pancreas, syempre, it's just the same as the pancreas of an adult that is for insulin secretion. Okay, so this arises during embryonic period. This arises from the dorsal and ventral pancreatic duct from the endodermal foregut. Insulin is detected in the fetal plasma by 12 weeks. Fetal pancreas corresponds to hyperglycemia by secreting insulin. Okay. So by 16 weeks, most pancreatic enzymes are present and concentration increases with gestational age. Okay. Next is the urinary system. This is what I was telling you a while ago. Kidneys are essential for survival, not actually that essential in survival for utero, but can influence amniotic fluid composition and volume simply because abnormalities that causes chronic fetal anuria or hindi umiihi yung fetus are accompanied by decrease in amniotic fluid or you call it oligohydramnios and then pulmonary hyperplasia. Because as I mentioned a while ago, how does fetus breathe inside and how does it regulates amniotic fluid? It tries to swallow the amniotic fluid. Iihi niya, swallow iihi niya. Okay? Aside from regulating the amniotic fluid, it also tries to make the lungs mature. No? Yung pag-inom at pag-ihi, pag-inom at pag-ihi. It also makes the lung mature. Now, what happens if you have, again, decrease in the amount of amniotic fluid? Konti lang yung naiinom niya. So what will happen to the respiratory tract? Patient or the fetus can prone to have pulmonary hypoplasia or maldevelopment of the pulmonary circulation. Okay. Endocrine gland, almost the same as our different endocrine gland. Okay. We have the pituitary gland, and these are again the different hormones that are secreted. If you can still remember, the adenohypophysis and the neurohypophysis, so same function as that of the adult. Okay, although the different hormones hindi pa siya nagfa-function na kasing mature ng function niya sa adult. Okay, but the hormone secreted by the pituitary gland is the same. Thyroid gland also the same, no? Usually, the pituitary thyroid system, this is the most important amongst the endocrine system because again, if you have a decrease in the amount of the thyroid hormones in utero, then that patient can develop congenital hypothyroidism, right? So, at the end of the first trimester, the pituitary thyroid system is already functional. Ibig sabihin, nagkikreate na siya ng sarili niyang thyroid hormones. Okay? So, placenta prevents substantial passage of the maternal thyroid hormone to the fetus by rapidly deiodinating maternal T3 and T4 to reverse it to T3 in an inactive thyroid hormone. So this prevents congenital hyperthyroidism to happen. But sometimes, no, like if there will be TSH antibody that can cross the placenta, this can stimulate the gland to produce thyroxine. And this is one of the reason naman for congenital hyperthyroidism. But this is something pathologic. But normally speaking, no, if there will be an increase in the thyroid hormone sa mommy, most of the time, nababalance naman yan ng baby. Pero pag antibody na yung pumasok, hindi na yan masyadong nakokontrol. Okay? And that's how naman the congenital hyperthyroidism usually starts. Okay? Adrenals, no, cortisol naman yan, if you can still remember. Okay? So fetal adrenal glands are usually 10 to 20 times larger than in adults. And this supplies, again, cortisol. And remember, your cortisol, no, can actually helps the lung to mature in utero. Okay? How about immunological system? Immunological system, we're talking about the different immunoglobulin. Okay? So fetal immunoglobulin consists mostly transferred by your immunoglobulin G, now, which starts at 16 weeks, progressively increases with the bulk of IgG acquired during the last 4 weeks, thereby preterm neonates are poorly endowed with protective and maternal antibodies. The most important among the immunoglobulin is the immunoglobulin M and immunoglobulin A. Okay, yung immunoglobulin M responds due to fetal exposure to infection, alam niyo naman to, and remains for months. While your A naman is something that is protective, and this is usually from the ingested colostrum. Okay, that usually protects the baby from enteric infection. Musculoskeletal system, origin is mostly in the muscles and the bone. Last few slides na ako, no? And bone in the mesoderm. Skeleton arises from a condensed mesenchyme which eventually forms hyaline cartilage models of bones. Osteoclasts arise from erythroid and myeloid progenitor, and ossification centers are developed by the end of embryonic period, and bones are hardened and endochondrial ossification. So, if there will be insult in the development of musculoskeletal system, ito yung mga common na nakikita natin, yung mga achondroplasia, yung mga dwarf na katulad nila Dagul. Okay? So there will be dysplasia, musculoskeletal dysplasia as what we call it. Okay? But some of the musculoskeletal dysplasia are actually lethal. One is your thanatophoric, no? Congenital abnormality or skeletal dysplasia. But the most common that we see is the achondroplasia. Yung nakikita nyo sa circus na maliliit na tao pero ang lalaki ng ulo. Okay, so those are skeletal dysplasias. Only if an insult happened and it targeted the musculoskeletal system. Okay. How about energy and nutrition? So there are three major energy storage depot of nutrients. Those are the liver, the muscle, and the adipose tissue. Okay. So there is an increased level of glucose that maintains insulin, resulting to maternal storage of glycogen, and amino acids are stored as protein and excess stored as fat. Okay. Transport of macronutrients is based on maternal supply and environmental stimuli, with placenta acting as nutrient sensor. So during fasting, the glucose is released from the glycogen and augmented by free fatty acid and there will be activation of lipolysis. And please do remember that among the glucose, fat, and protein, glucose is the major nutrients for fetal growth and energy and transported into by facilitated diffusion. Now, if you can still remember, leptin is a polypeptide hormone that was originally identified as a byproduct of adipocyte, and it regulates the energy for hemostasis by curbing appetite. Okay? So usually leptin is produced by the mother, fetal vascular endothelial cells, and syncytial trophoblasts. And 5% usually enters fetal circulation, and 95% is transferred to the mother. Leptin usually peaks 34 weeks and correlated with fetal weight. If you can remember and hear the word leptin, di ba it has something to do with obesity, not particularly maternal obesity, no? Pag naririnig niyo yung leptin, okay? So maternal obesity begets fetal macrosomia, and it is hypothesized that maternal obesity affects fetal cardiocyte growth that may result in fetal cardiomyopathy and even congenital heart disease. So abnormal levels of your leptin is associated with fetal growth disorder, gestational diabetes, and preeclampsia, but not maternal obesity. This is strongly correlated with metabolic syndrome in childhood and adulthood. So they are actually talking about leptin with this one. How about free fatty acids and triglycerides? So late in pregnancy, substantial amount of substrates is transferred to the fetus as fat, and at birth, a term newborn has an average of 15% of fat in the total body weight. No? So maternal concentrations of low and high level of triglycerides are associated with the development of congenital abnormalities. But please do remember that because of the metabolic metabolic or physiologic things that happens during pregnancy, free fatty acid and triglyceride in the maternal circulation usually gets higher than the normal. Okay, but they are not given, or these are not corrected by the anti-lipid medication. Bawal kasi yon. Okay? But in the fetus, again, there is a preferential placental fetal transfer of long-chain polyunsaturated fatty acids, but not the lipoprotein lipase. This arrangement favors hydrolysis of the triacylglycerol in the maternal intervillous space, but preserves neutral lipids in fetal fat. In the minerals and heavy metals, the most important is iron. Okay. So iron, you have a unidirectional transfer of iron. That's even if there will be severe maternal iron deficiency anemia, hemoglobin mass is normal. And during pregnancy, the iron supplementation that we give to the mother is not actually for the fetus. Kasi automatic sa fetus, just like the calcium. The maternal iron stores and calcium iron stores in the fetus, in the mother side, goes to the fetus normally. So 30% usually goes to the fetus normally. So kung ang mommy is anemic to start with, tas automatic na pupunta pa sa baby niya yon, kasi hindi siya magkakaroon ng iron supplementation, definitely mas bababa pa yung hemoglobin niya. That's why iron and calcium, same goes through with calcium. That's why iron and calcium is one of the added vitamins that we give during prenatal checkup. Okay? Last 4 slides. Okay? How about the placenta? Now, placenta is the organ of transfer between the mother and the fetus with a bidirectional maternal-fetal interface. Okay? So maternal oxygen and nutrients are transferred to the fetus, whereas carbon dioxide and metabolic waste are directed back to the mother. No? So the bidirectional transfer depends on the process that allows or aid the transport through the in situ trophoblast. Okay? So breaks in the chorionic villi permits the escape of fetal or placental cells into the maternal circulation, and the condition is just like the Rh isoimmunization and fetal microchimerism. Okay? So this is what happens inside the placenta. So there is no direct connection between the maternal vasculature and the fetal vasculature. They only meet at the intervillous space. Kasi once the barrier is broken and fetal blood crosses the maternal blood, magkakaroon ka ng emboli. And that is something that is toxic because it can cause mortality to the mother. Okay, so please remember that there is no direct connection. Okay. So maternal blood in the intervillous space is the primary source of maternal fetal transfer. Placental transfer of substances must first traverse, again, the in situ trophoblast, attenuated by cytotrophoblast, the villus stroma, and the fetal capillary wall. And these are the different transfers that are involved. Okay. So most substances with molecular mass of less than 500 Dalton passes readily through the placental tissue by simple diffusion. However, some of the low molecular weight compounds undergo transfer by facilitated by the in situ trophoblast, just like your insulin, steroid hormone, and thyroid hormone. While high molecular weight substances usually do not traverse the placenta except for IgG. Placental oxygen transfer is blood flow limited. Oxygen delivery is usually 8 ml of oxygen per minute per kilogram of fetal weight. So placenta is highly permissible to carbon dioxide, which traverses the chorionic villi by diffusion more rapidly than oxygen. And this is due to because, again, partial pressure of carbon dioxide averages 50 millimeters mercury, which is 5 millimeter higher than in maternal blood. Thus, fetal blood has less affinity to carbon dioxide, favoring transport back to the mother. And there is another reason why there is a decrease in oxygen affinities because of the maternal hyperventilation, no? The respiratory alkalosis that gives the decrease in the partial pressure of carbon dioxide level. So that is again in the placental circulation. So please remember that there is no direct connection between the maternal side and the fetal side. Okay, they only meet at the intervillous space. Okay, so I think that's my last slide for embryogenesis and fetal